morning, everybody. And thank you, Renata, for the invitation. I appreciate Chad and Terry's comments, and I think I'm batting cleanup or color analysis or whatever analogy you want to use, tying in the primary care aspect in. I'm here representing family physicians as well as our other primary care brethren, the primary care pediatricians and general internists, but I have family medicine in my blood, so you're going to hear a lot about family medicine. So a little bit about the AAFP. You heard a little bit yesterday from Dr. Schroeder and some of the activities we've done with SCLC. We have 115,900 members, so we really are the front line of primary care. And you can see our number of office visits there. We see a lot of folks, and a lot of them are smoking. A few are less than they have been, but we're working on it, and we want to keep working on it with you. We have strategic goals in our academy, and as you can see, a lot of these really do apply to our folks that are smoking. I'm going to hit on a couple of them in particular. You've heard a lot about patient-centered medical home. That's our buzzword that we use, but health homes, whatever that works for you in your environment. But this is a big push for us and really important because we think it's the best care for our patients and also the best model for our physicians to provide the most optimal care. And one of the things that I think is really important I want to share with you today that ties in with Chad and Terry's comments is that within the medical home, we have set principles that I'm going to share with you, but we recognized that we were missing, it was sort of implied, but really missing that behavioral health component. And then in this past March, just a couple months ago, we came out with a very specific document that addressed that it really wasn't implied, it needed to be very explicitly stated about how to integrate behavioral health into the medical home. And tobacco control, prevention, and cessation ties into this so well. So I really wanted to emphasize this and have you be able to see it so you know where we're coming from there. And it was published in the Annals of Family Medicine if you want to get a good read in. So these are the organizations that were involved with it and endorsed by several other organizations, including the American Psychological Association and the AAP, as well as all of our sister family medicine organizations. And these are the principles of the medical home, not just the behavioral health part, but if you take a look at that, that looks a lot like behavioral health. That's why I said it was sort of implied, but we didn't really have all these components of the behavioral health in there. But we want the person in the medical home to have a personal physician. We want them to have a physician-directed care type team, the whole person orientation, which we've heard over and over again, which is so key. Coordination of care, the follow-up, the infrastructure to really address their needs, quality and safety, and really being able to check and seeing that those goals are measured and completed and followed up upon, that access is there, and then the payment piece, which I think is really key as well. And we're seeing that more and more as we're tied into bundled payment and follow-up and the ways we can tie in public health and primary care together. And these were some of the key pieces I just wanted to highlight in the particular behavioral health document. Some of the things we found out also, one of the things we've really been involved with AAFP is the integration of public health and primary care that they talked about in the IOM document, working with ASTO on that in their collaborative. And some of the key components of that have been language. A lot of times we're on the same page, but we're not saying the same things. And that really does matter. So getting some of that language barrier down so that we're really actually helping the patients. And understanding the role of the family. We feel like we do this pretty well as family physicians, but sometimes when we're doing referrals out, sometimes that gets lost. So I think it's important for all of us working together to help our patients in prevention and cessation efforts. And then looking at what are our skill sets, what's the role delineation, understanding how behavioral health is so important to help us do this. I hear time and time again, I know I need to do this, but I don't have time in the office. The pressures of the primary care physician are really tough, and we have those targeted interventions, which I think most of the time we're doing a pretty good job with. We have meaningful use, but it's not enough. And we realize that, and it's frustrating. So we really need to tie this in together with the expertise in the behavioral health community, and that's coming up more and more. So the ways that we can do that need to be recognized. Interdisciplinary training. We're seeing this happening more and more with medical home. Thankfully, we're starting to see it more at the medical school level with primary care and certainly at the residency level as more residents are training in medical home residencies. So they're training in an interdisciplinary setting and seeing that work. so that we see behavioral health clinicians embedded in practices, or at least the referral patterns in medical neighborhoods better integrated, but there's always room for improvement. And then research, how do we document that this optimal provision of care is occurring? And all the way down to the financing piece, which in some places they're doing very well, in other places it's still a big challenge. And then how do we look at this whole person care? How do we look at it so it works across communities and across the country? And how do we make sure that the advocacy for what acts are already in place are really occurring? Just a couple of words on some of the things that we're already doing at the Academy I wanted to share and tie in. We have a program called Ask and Act, which you can access at askanact.org. We talked about it a little bit yesterday at our presentation. It's an evidence-based strategy based on the 5 A's, simplified down to the primary care level so that we can do it quickly in those intervention times that we have and can bill and code for. And it gives a team-based approach. So it's not just the physician, it's the whole office, which is key. Physicians are important. It's evidence-based, that mentioning it at every visit and working with the patient at every visit is very critical to helping patients stop smoking or prevent starting smoking. But we need the entire team involved. And so we have a series of materials developed so that it can help the whole team do that. And there are things that can be downloaded free. We have print copies free to members that are available for purchase to non-members of our Academy. But they've worked really well, and I think it's an important resource. And I have examples if you want to see them. We have developed from that our Office Champions program. Some of you got to hear about that yesterday. And we have different models for our Office Champions. We have one specific to FQHCs, which you got to hear a couple of our Office Champions talking from Georgia, who've done a phenomenal job, but we have them spread throughout the country. Those are some of our champions, and they've done a fabulous job. But we also have traditional office practices that are in the Office Champions program. And we've done it at the Academy for other things such as immunizations and obesity treatment as well. But it's looking at team-based care basically within the medical home, and it's essentially a big quality improvement project, looking at how the team impacts the care, how they know their patients, how they can really get involved, and it does make a difference, and we have some great outcomes to show for that. And there I've got some of the resources, how we used our Ask and Act to do that on the smoking cessation, and specifically the FQHC report. I talked to some folks within the Academy, some of our members, and including some behavioral health folks that work within medical homes, and asked them what their thoughts were. How do you make this work? And what are the barriers? Because I practice in a medical home myself, thankfully with behavioral health embedded. But I wanted to get some thoughts beyond my own, so these are a variety of folks that shared. So these are what they thought would be some best practices from their experiences. And the ideal was having someone right there on site, and we found that with other pieces of the medical home. The more services you can actually provide in the medical home, the better. But that's not always practical. Not everyone has their own psychologist or other behavioral health specialist, but if you can, that's wonderful, and provide point of care service. Also within the neighborhood, the medical neighborhood, meaning outside the medical home, but you have an integrated network. So the folks that didn't have an on-site psychologist or other behavioral health specialist worked hard to make their network very successful and identified behavioral health specialists that they could refer to that felt an expertise. And I really resonated with what both of you were saying about behavioral health team members not always feeling comfortable, because they shared that with me too. I didn't get that training. And as a physician, I thought all people with behavioral health training, that would be part of their repertoire. But we had to seek out people that really felt comfortable with that too. So that was eye-opening to the physicians on the team. So it was something we had to establish, that that we had the folks that really wanted to provide that care and felt that they had the expertise, both on the medical side and the behavioral health team side. Also, we wanted to find other community resources. So we had the health professionals involved, but also other community health resources, such as using quit lines. We used the cards that Dr. Schroeder mentioned yesterday. AAFP does have our own branded cards that we used from the Smoking Cessation Leadership Center, which have worked very well through our Ask and Act program. And then also working with other community organizations that we can find and a lot of our members have done this. Some suggestions have been made, and one of you alluded to, I think both of you actually, the EHR issues are theoretically should be a help, but oftentimes a frustration because of the interoperability issues or lack of interoperability. Oftentimes we have trouble communicating from office to office or to hospital or to other providers. And then we also have the extra challenge of confidentiality with behavioral health. So some suggestions our members made about that they've had more success with are just having a brief referral form when they go for smoking cessation or other behavioral health to a behavioral health science person to facilitate communication and optimal care, so that they would send something along with a release of information that the patient was comfortable with. So that is another practice that was often suggested. And then really recognizing within the primary care setting that the physician doesn't have to do it all, and shouldn't. The physician should be involved, they should be a key leader, but and the clinician, whomever's seeing the patient. However, the team-based piece of it is really important, and I think our Office Champions model really demonstrates that. Ms. Lavender that spoke yesterday, the MA, that was so critical to making their team in Georgia a success and getting their smoking rates down so much in the practice, in addition to their physician champion. So I think it's really key. Barriers. Why do you always get a tickle in the middle of talking? So payment always comes up. The physicians are feeling very crunched. They want to help the patients, but they feel like they have that time and they need to move on. So I think having that multidisciplinary team and the medical neighborhood available is very important. The time ties right into that. Knowledge deficits, we've all mentioned that. Feeling like I'm not sure I have all the information I need. That's where we as an organization can help out with the support, but we need to continue to educate all members of the team to feel like they have the ability to really help these folks. Transportation. This always comes up. In my practice, I've always helped indigent patients. And that is a key thing. So that's where quit lines and other methods that we can help, and if we can work with identifying transportation. But this is identified very frequently by our members as an issue. The transportation to the office, transportation to support groups continues to be an issue. Lack of effective internal flow. So looking at some of these things like our Office Champion models, looking at point of care services, not just having the physicians doing it, but having a really organized system to help the patient. When they identify that a need is there to help a patient quit is really important as well. And then having a referral process in place that works very smoothly rather than just going, oh, now what do I do? I have a patient as a smoker. And there are oftentimes much better effective models than that in practices. But really pointing out that they need to have something in place can be very important as well. Opportunities, integration, the theme word of today. And we have really talked a lot about integration of public health and primary care. This is a key message and function of what we're looking at the Academy, working with several organizations, particularly ASTO, and the de Beaumont Foundation's Practical Playbook. That's another resource that I don't think got mentioned, and I didn't put it in my slides, but if you check out practicalplaybook.org, that's come out of this initiative, and I think that would be helpful to you as well. Looking at the medical home and the medical neighborhood, and continue to really look at how we help our patients access benefits. And the bottom line is education, education, education. So I think it's time for us to move on to questions, and I appreciate your time today and to have all of us here. Thank you.
So I'd like to thank Chad and Terry and Julie again. Now it's time for questions, thoughts, ideas to share with the panel. So where are the mics? Oh, I see, over here, okay. So questions. So I do, as I was listening, I had at least a couple of questions that I wanted to ask. You know, you talk about integration. This whole panel was focused on the necessary integration that has to occur between public health and behavioral health, public health and primary care, behavioral health, public health, and primary care to really get at reducing tobacco use among individuals with behavioral health populations. But you know, it's easy to say integration. Can you talk a little bit about, in your experience, what is the skill set that's really needed to push integration? Each of you have pushed this issue, but what skills did you rely on as leaders, as individuals to make that happen? Because I know working in systems, yeah, you could say let's integrate, but the reality is that's hard work. So.
I can start to answer that question, but then they'll have better answers than I even, so. You know, we really approach this work from a stages of change model. And so an organizational stages of change model. And so really what we try to do is work with organizations and really try to get a feel for where they're at in their stage of change. You know, are they really pre-contemplators, contemplators, whatnot, and then working with those organizations to figure out, based on that stage of change, really what the next step is for them. And that's going to differ across, you know, as far as the skill sets and so forth and where you want to start. So it's really just like we would meet our clients where they're at. It's meeting the organizations where they are at and not assuming they're at a certain place. And so that might be just initially, you know, from when we talked about the value proposition, the skills proposition, the business, it might be, you know, we need to really just start with that values proposition first and then move into what are the skill sets from there and doing an analysis, basically a mini evaluation of what skill sets exist and then building on the strengths that folks already have. And so that's, you know, a basic platform, a philosophy of how we approach this. And then as far as some of the skill sets themselves, maybe if both of you want to speak to that a little bit.
The number one thing at the practice level that I experienced personally was communication. And it really involved, we would actually go out and meet with practices, meet with other professionals, and sit down face to face and say, how can we make this work? When we were just trying to send a fax or just trying to give a call, it didn't really work. But when we went down and sat face to face and say, here's what our patients look like, sound like, here's what their needs are, here's why we're not having success, what would work? And we would find out real quickly that we could come to an agreement. And we really weren't fighting or anything, but we really had not communicated that before. And they say, oh, if we just did this, the patients their needs could be met. And so I think communication is absolutely the key set. And it was something that didn't take a whole lot of time. It took a little bit, but in the overall long run, it made things go so much more smoothly, and the patients were so grateful, and we could set up some processes and systems for those patients to have their needs met. And so I'd say communication and really setting up the networks.
So I would of course agree with both of those comments. And I think starting with something small, Renata, in terms of working together and forging those relationships, I would say there's never been a stronger relationship than there is today between our Department of Public Health and our Department of Mental Health and Substance Abuse Services. And we have several initiatives that are taking place. And some of those are really big and some of those are small. And one commonality that we have is that we're all very passionate about what we do. So both of these agencies are very mission-driven. We have people who believe very, very strongly in what they're doing. And it's not just a job, it's really something that people take to heart. So I think being able to join around something where there's that kind of shared vision can make a huge difference. We have an initiative through ASTO, the Association of State and Territorial Health Officials, and United Health Foundation, collaborative between the Department of Mental Health and Substance Abuse Services, Department of Health, and the Department of Tourism. So think about that. So we're really looking at wellness opportunities, and we're starting with our own staff and looking at our own data, looking at our insurance, making sure that there's good access to tobacco cessation for our own staff. We've gone through this health leads assessment to really help us get a sense of where we are and identifying some of the barriers to forward movement. And it was very enlightening doing that, but it was work that we did together. As a result of that initiative, we met with our state insurance group, we met with the governor's office, all focused on kind of moving the ball down the field in terms of employee wellness, again, hoping to model that and really to take that on. But I agree, especially around the communication piece, but I would encourage that willingness to start with something small and to partner on those types of initiatives.
And if I can just add to that, because I think it's a great add-on to what Terry just said, is that, I think that for a lot of agencies, this can just seem so overwhelming. Yeah. It seems like such a huge project. And so it's really instilling that culture of what I would call internal, quality improvement, using things like PDSA cycles and things like that. But it's really trying to create a system where folks can instill that culture of evaluation, where folks can look systematically at small changes over time and look at whether they worked, fine-tune them, and so forth. And based on that success, it's so much easier to get things going after that.
Great, great. Maybe one other question that I have, because I've heard at least in all yesterday and some today that behavioral health clinicians have the skill set already to do this integration, particularly in primary care. But from the kind of the flip side, and I guess Julie is probably the best person, what is it that you would expect of behavioral health counselors in an integrated, primary care setting? What is it that we need to, yes, we have skill sets, but what is it that we need to know about working in primary care that is a little bit different than working in a behavioral health treatment program?
I think the acute intervention would be the most common thing, and how to do the sustained follow-up after that. But the acute, we've identified an issue, and then how to do that initial brief intervention, and then the follow-up after that.
Okay. I know I've listened to one webinar where they said the pace is very different than working in primary care. And even though we may engage our behavioral change skill sets, it's at a little faster pace than what we're used to.
To your point, the psychologist I spoke with that was working in a patient-centered medical home in a family physician's office said that she had talked to several of her colleagues, and they had tried that, and the pace was different, and it was uncomfortable to them because they were used to a more cognitive behavioral therapy, more of that sustained and longer visits, and not doing that, hey, come here, I need you to talk to this guy, I need you to come over here and meet with this patient, oh, we have this crisis over here, because it wouldn't always just be tobacco cessation all day, usually with these counselors and therapists in a primary care setting. So that some of them really thrived on it, but others would do it and say, this is not what I'm trained to do. They would feel really uncomfortable, but others really did a great job and really enjoyed it, and others felt uncomfortable. So the skill sets are there, but it depends on how you work and what you feel comfortable doing.
So I would say just a reminder that practitioners in behavioral health have a lot to offer. They really do. So you need to remind yourself at times that you have the solution to many of the problems that others are struggling with. So what am I going to do in the emergency room and the primary care office where that skill set doesn't necessarily reside, and there's a challenge in really meeting the needs of the person that's sitting right in front of them.
And it comes up every day, all day.
Right, and it's very, very prevalent. So you can actually be part of the solution for individuals. And I would also add to remember that in our kind of partnership mode, that we have things to offer. Usually in partnerships, we say, Chad, I want you to partner with me. Can you give me $10,000 and we'll go do this? And I ask for something, right? I usually ask for something in partnership. But I think, there you go. But we have a lot to offer too. I think we have the solutions. I think it's part of the primary care solution. It's part of the emergency room solution. It's part of the struggles in health departments across the country, and behavioral health has the answer. So I think if we're able to go to the table and say, well, actually we're willing to work with you, and then it gets into the time issue, then hopefully you'll get paid for it, and that gets into the sustaining part of it, and making sure that we're tapping into those funding models. But I think to make sure that you're offering, and it's definitely a value proposition. Behavioral health has a lot of the answers. And right now, because of the shifts in the landscape, I think that the rest of the world is going to be much more interested in population health, which they have not been so much in the past. And if you don't figure these pieces out, you're going to have a hard time moving the needle in your communities. You really are.
I would agree. Go ahead.
To that point, I think we're going to see, I agree completely, a lot more population-based health and a lot more bundled payments around that, and so that the behavioral health professionals will be included in that. And so the payment, I mean, we don't know, it's all evolving very quickly, but I think that you're a definite piece of that puzzle and that solution, and we need to be looking at that as this advances.
And just, really looking more at the public health side, well, both sides, primary care. One of the issues that we've really seen is that we speak different languages, perhaps, and so it's really trying to learn the languages. And when we started working with public health, that was very much the issue, is that public health, county public health and state public health kept saying, we want to work with behavioral health, but the door's getting shut on us. And the issue was that they were speaking a different language. And so, they would say something population health related, and the behavioral health folks would say, what are you talking about? That has nothing to do with us. And so it's really trying to find that common language, or at least learn each other's languages.
So to that end, the language, I mean, some years ago, I was asked to do a speech at Hopkins for around, public health and integration, and the language issue, and I found myself spending a lot of time kind of like translating. Okay, so a public health model is this, 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 and this, and then trying to compare it to what that on the comparable side on behavioral health. So I think that maybe the plea or the pitch is we need to think about how to get that on paper. We articulate that and say, okay, language, but so what does a public health model look like in or for behavioral health? So what does it mean, so, yes.
There's a great section, I know I'm preaching the playbook here, but I really believe in it, so if you can't tell. The practical playbook has a great section on integrated language.
Oh, okay.
So if you would like to check that out, you can, and it's a dynamic document, so it's always being updated. So if we need more behavioral health language in there, we can always add that in. But it's certainly got the public health and primary care language barrier addressed, I think, pretty darn well, but we can always update that too. But it's got a good section on the language barrier and how to overcome that and what those different issues have been and how to move forward. So
okay, so we could offer some suggestions around the behavioral health, because it is, I think we're all doing very similar work, but we just call it different things, and it really does matter. Yeah. Okay. Any other questions? Yes.
Good morning.
Good morning.
First of all, this has been a very informative couple of days. And I'll say one of the questions that I have is, where are you getting, in the policy and partnership and integration, I hear a lot of professionals talking to professionals. But I'm curious, where are the consumers or patients, and how are their voices and their feedback being gathered? One, not just by a survey, but also perhaps through an advisory committee to help better inform that it's not just working on one tier, but it's also trickling down into the consumer having a position of self-advocacy. Right. And so I'm just curious, in your work, where do you bring your patients' voices and experiences into your work and informs your work?
It's a great question. On the medical home side, for primary care, one of the key features of the patient-centered medical home is having patient advisory panels. So at the practice level, that's one of the key components, is that we encourage each practice to have, or groups of practices, or whatever type of organization you're in, to have the patients advising. When we did it at our own practice, we thought we really knew what we were doing. We thought we were doing great things for the practice, and sometimes we were, but when we brought our patients in, and we usually did it about quarterly, and it was extremely informative, and sometimes the things we were really working on and doing all this hard work, they're like, why are you doing that? That's what we really like about the practice. Leave that alone. You need to fix this. the patient ed in the waiting room doesn't have anything about pediatrics. It only has things about adults. Oh, okay, that's really important information. We really had never thought about that. So it was very helpful, and I think we need to continue to get that patient voice. And on the national scene, as we move these agendas forward, we need that same kind of patient voice. So thank you for your question.
I mean, I think there's lots of entrees into that. Every state has a planning and advisory council as part of the behavioral health system, and it's really educating the planning and advisory council too about they already know the impact they can have, but it's educating them about the issue itself and really kind of raising that awareness, and that's been a huge impact. But I'll tell you what, we really just use grassroots, and so that's why I'm such a huge believer in peer-based services, is that we train peers not only in the skill sets around wellness and tobacco and weight management and nutrition, but it's about policy. It's about how to amplify your voice in both organizational and state types of environments. And that's had a huge impact. I think that's been the basic, or the most fundamental impetus for change in a lot of states. It's the peers going up and saying, it's basically demanding that we want these services. So.
Well, thank you for the work you're doing, and thank you for your responses.
So I'm going to say just a quick word and a slight difference for public health. So everyone is a potential public health client, right? Everyone in the entire state. So someone who's not a patient today, maybe tomorrow, or someone who is a recipient of services. Basically, everyone's touched by the Department of Health. And we have developed a health improvement plan. It's called the Oklahoma Health Improvement Plan, called OHIP. And part of what we do in that process, we're revamping for the next 4 or 5 years. It's really our larger stakeholder strategic plan focused on population health. And we hold community listening sessions around the state. So we have about 12 to 15 of those that are taking place. Some of those are targeted specifically for tribal consultations. We have 38 federally recognized tribes in the state of Oklahoma, also targeting some populations that are typically underrepresented in surveys or other more kind of formalized processes going right into communities, being held at all different times of the day, evening, midday, 7 o'clock in the morning, really to accommodate different schedules, then synthesizing all of that information. In addition, we have surveys that are out and available to anyone who has access to the internet. So we pull all that information together and then develop our strategic plan. And I can tell you already we're about halfway through those community listening sessions, or community chats, we're calling them. Mental health plays very prominently, and substance abuse plays very prominently. So I know that that will be part, even though this is driven by the Department of Health, that will be very much part of that health improvement plan moving forward. We also have a lot of community coalitions that we support. Our department, through our Turning Point Coalition, supports about 69 grassroots coalitions across the state, really looking at local solutions to local problems. And it may be, putting drop boxes in for prescription drugs, maybe gang violence, whatever the particular need is of that community. So I think it's important to tailor that. So thank you for the question. Thanks.
Thank you so much, Regina. My only other caveat or bit of wisdom would be that every consumer peer organization always needs to be looking at the website of public health agency in a state. Like I know in Maryland, they have the public health, state improvement plan, or the health improvement plan that every county is responsible for. So, consumers and peers need to know what's going on at the public health. And again, one of these days it won't be public health and behavioral health. It'll be the health of people, and we'll be all working together. So maybe that's a good place, unless there is another question. Right, good, great.
I think
there are two, great.
Dr. Wood, in your presentation, you noted as the first barrier to ask and act, payment. And I'm wondering what the panel would say to the best ways for people to understand in an accessible way the payment system maybe you can already hear the frustration in my voice. Payment makes me sad. As a person who provides technical assistance, all of this is, I mean, it's really great, and I love values and everything, but these people got to stay afloat. And when they can't figure out how to get this paid for, even for Medicaid clients, it's, you know, the state Medicaid office puts out something that's completely unintelligible and blah, blah, blah. I don't mean to just like harangue it. What I'm looking for are specifics, resources or ideas or pathways for sectors of the health community to access reliable, up-to-date information about payment.
So I'll touch on part of the payment piece. I don't know about access to information, but one example for the state of Oklahoma, for the tobacco cessation through the Department of Mental Health and Substance Abuse Services, of course, a large segment of that, and you're right, it varies state by state, is funded through Medicaid. For those individuals who are not Medicaid eligible, the Department of Mental Health and Substance Abuse Services actually has funding to pay for tobacco cessation services through the providers. As you mentioned, SBIRT, and that's a nice example, the Screening, Brief Intervention, Referral, and Treatment Program. There's a nice example of developing an evidence-based program that had great support, that then the CPT codes were developed at the federal level so that those were approved by Medicaid or through CMS, and then a state-by-state option, being able to adopt that. So I think that advocacy at the state level is really important. The money can be a frustration, but having worked in the private sector as well, I can tell you, no money, no mission. We're all mission-oriented, but if you can't pay for it, you can have values and ideals all day long, and you need to figure out a way to pay for it and sustain it. So
Or if it takes you so long to figure out how to pay for it that you lose the will to provide the service,
Right.
I think it's an almost equal barrier.
Right. I agree with you entirely, and I'm very sympathetic to that, and I'm hoping that, as there is in the state of Oklahoma, that there can be groups that are developed, if not there already, who have a strong voice that will be singing the praises of those programs, and money really does follow those values sometimes, and many times that's because it's articulated by advocates or consumer groups or others who are making sure that people appreciate the value of the service.
What I found is, in the evolving healthcare context, this is changing almost weekly. And so it's so hard to keep. So, I feel like the best we can do in that continuity of care hub model is figure out who's going to be bulldogging that and trying to figure out what are those algorithms and workflows that are changing over time. That takes resources. But that's where I really feel like we need to go. And unfortunately, that needs to be updated monthly right now. But I think that every community needs that right now. So in Colorado, we've been trying to work on that. But again, it's more that sustainability of who's going to do it over time.
So, Dr. Morris, do you have somebody who does that, who does that at the state level?
That would be me in Colorado
Okay.
right now.
Thanks.
and it's because that, I say that, but it's really the state public health department has taken that on and said that's part of my work that they're funding.
Okay.
And so I think that, that might be where it goes. Maybe it's the public health system saying there has to be someone who's really doing that work.
Okay.
Well, we've tried to, it's really challenging. We've tried to come out with some billing and coding guidance for our physician members at AAFP, looking at the G codes from Medicare, looking at third-party payers, which vary. We also look at the state to state, but like you said, that's evolving so quickly with the current state of ACA, which is promising, but it's evolving very quickly. We have a regulatory person federally that follows all of that, but it changes really quickly, and the state to state issues are very different, and particularly with Medicaid. I'm in a state that's complete opposite of Oklahoma. When I was practicing, that all the settlement money went in a general fund and went poof, and there's really very little support for cessation or to help patients. So it's a complete opposite and poor situation. So I wish I had a better answer for you, but it's extremely dynamic and it's a very state-dependent process right now. And we're trying to do the best we can as a national organization to guide members, but it changes very quickly, and it is frustrating.
Just one more word, and this is more just my own hope, maybe. You mentioned bundled payments earlier. I really do believe that the world is moving more toward bundled payments and kind of population health outcomes. So when money then is the driver for population health, and population health is the way that you get reimbursed, that's going to change everything. It really will.
And it will unite public health and primary care.
It really will. I think you'll have people knocking on your door saying, wow, we really need you because my payment is going to be dependent on driving down these rates of bad things happening. And again, you have the solution to that. And that part of the world that's been marginalized and separate now is going to be not necessarily begging, but it's going to be very interested in what you have to offer.
And we'll need to work together.
And we'll need to work together to get there, right. It's going to change the dynamics significantly.
Thank you.
I live in a microcosm instead of the big world. I'm a tobacco treatment specialist, and I have a real agenda. I'm wondering, as we talk about the medical home, the medical neighborhood, are we doing enough to raise awareness that there is specific training for tobacco treatment specialists? Cheap at the price, cheaper labor, but very focused on helping people from whatever background to learn the process, go through the process of getting free from tobacco. Is that being built in as you think of systems, as you are encouraging the integrations? Think cheap labor.
So you're talking about tobacco treatment specialist training, correct? And so, part of the issue, and this is going to be unfolding, but a lot of the healthcare policy has been excluding tobacco treatment specialists. It's excluding a wide range of disciplines. And so it's trying to figure out, maybe that's through bundled payment that we can include those folks, but right now under the ACA, for instance, a meaningful use, some of the people that have the best skills are excluded from that. And so, I don't have the answer to that. I bet you have the answer to it, right?
So I know in the state of Oklahoma, there actually is a lot of training going on with the peer recovery support specialist, really to make sure that we're building that kind of network of people who have that expertise. And again, it's not being done because it's cheap labor, although it would be. It's being done because of cultural competence and really the ability to be more effective than a lot of other interveners would be. So again, you might want to talk with one of those three people at that table right there, because I think it's an impressive outreach.
The other part of this is, you mentioned TTS, but this is pure specialists, right? So how can we get pure specialists paid? There's codes there. There's a lot of codes there. But the question is, are states turning them on? And so things can happen at the federal level, but actually states have to implement at the local level. So it's the same sort of issue with peers as well.
Well, I'd like to thank again the panel and all of you for the dialogue and the questions. This is, I would say, emerging, the way of the future, but it's not really emerging, it's now. And we will continue to try and bring to the audiences that need to hear it how to better integrate public health, primary care, and behavioral health, because we are all working towards the same end, So with that, we're going to take a break, and I would invite the people that are sitting along the wall to come and fill at the tables, because we're in 15 minutes, we're going to have our closing panel, which is, I'm really looking forward to, on the issue of e-cigarettes. So we'll see you back here in 15 minutes.